Today I will be discussing the posterior composite restoration. With the increase of knowledge of the microhybrid composites, patients are satisfied with a restoration that is tooth-colored, as well as dentists are satisfied with the long-term success of these restorations. But to achieve this success, we need to be able to understand the preparation itself and also the reasons of the manipulation that we need to use certain composites in certain areas. Okay, so the topics of discussion that we will be covering are the indications of posterior composites, the preparation and design, the selectional matrix technique, the composite placement, finishing and polishing, and custom tinting and opaquing we will briefly cover. So for the indications, mostly the posterior composites will be most successful if they are of the small to medium size restorations. They are most successful in the first and second premolars as well as the molars due to isolation of these teeth. Occlusion obviously should be directed if the restoration can be on the tooth surface rather than the filling surface for obvious reasons. And isolation of these teeth is imperative because any moisture can decrease the success of the restoration. But just a side note, due to the COVID that is occurring probably from now into the future, rubber dams are going to be used as well as in your office if you have isolate. Isolation of the mouth is going to be highly recommended, not only for the restoration itself, but for the protection of the dentist, the assistants, as well as the patient. Okay, so for the composite preparation, the conventional preparation design that you see up above, that to me looks like a preparation that was indicated for an amalgam. You see the extension for prevention, which the restoration is extending into the isthmus as well as into the mesial pit, as well as the preparation itself. It looks more like I said, an amalgam preparation, which then was removed and the composite has been placed. More ideally, you see the bottom slide that says the slot preparation design. This is an indication more of the preparations that we see today, trying to stay more on the conservative basis. You see the slot design. It is not rectangular, it is more circular. If it was me doing this preparation, I would indeed remove the staining that you see on the occlusal surfaces, and I would probably seal it with a sealant. Composite preparation designs. Because composites are a mechanical retention as opposed to the amalgam that was more of a, the composites are a bonded restoration as opposed to the amalgam, which was more of a retention with undercuts and grooves. This is why the restoration that you see here could be so small as to be removing the decay. As you see here, a sealant with the composite was placed. The sealant probably to seal the grooves, and the slot is to remove the decay. Composites, this is a review, composites versus the amalgam. Composites have round internal line angles. They are micromechanical in retention. They do not always have to break the proximal wall. Most proximal walls are prepared with an obtuse exit, and the obtuse exit increases the obtuse angle increases the obtuse cavity preparation increases the enamel rods that are there that will be present for when you etch to increase the retention. Amalgams, on the other hand, have sharp internal line angles. We know that we have to reduce more of the dentin. They're macro mechanical in retention, and you do always need to break the proximal contact by 0.5 millimeters in order to assure that your matrix band is going to slide between the teeth, as well as when the patient flosses, you want the patient to be able to floss and to clean the junction between the amalgam and the tooth. So now we are going to be discussing the types of composites that we will be using as an indication to where the perforation exists. So the closed sandwich technique is a preparation that the composite, because the preparation is still enclosed in enamel, you have the gray area, which is your glass ionomer, and then on top of that, you have your composites. The glass ionomer does not extend past the CEJ, and the composite covers the glass ionomer. And that, again, is because there is still enamel that the composite touches. The open sandwich technique is when the restoration no longer is in enamel. The enamel is completely removed due to the decay. Therefore, what you have is you have a glass ionomer base which extends all the way. It completely covers the pulpal floor, and as well as either the mesial or the distal preparation. In this case, I'm going to call this the mesial, and the glass ionomer does then get exposed to the oral cavity. The composite then, for the open sandwich technique, is only on the top portion of the tooth. Okay, so now we're going to be discussing the TOFFLEMIRE versus the sectional matrix system. The TOFFLEMIRE system, which we have been using for the amalgam, at times can fail to restore the proximal anatomy of the tooth, has a thin contact at the marginal ridge. This is one of the drawbacks. Can be a large fluid trap, depending, now that is depending on the size of the wedge that you use. If you use too large of a wedge, instead of having a nice proximal contact that the matrix band is against the tooth, you have the wedge, which causes more of a teepee shape, and you will have a large food trap. There is an increased likelihood, obviously, that there's a fracture because the occlusal interferences, recurrent decay, and periodontal disease can form. The reason for that is that you have less of the amalgam because you've put in too large of a wedge. You do not have the bulk of the amalgam in the box. As opposed to the sectional system, which you will see down below, it is operator friendly in retaining the system. It has the band itself has a natural contour. it will provide anatomically correct contacts. The contact at the height of contour is established by the bitines, and the contacts are tight, it says here, so that you will need hemostats to remove the band. I have to just add, if you use the TOFFLEMIRE system correctly, you should also achieve all of the things that the sectional system can do. Again, as I've said in the class, it all depends what it works in your hands. Okay, so this is a picture of the sectional matrix system. You will see that you have all of the equipment that you need. You see, if you have a deep filling, you have the matrix that have what I call the rabbit ears, which just is an extension so it can get past that deep contact. Okay, here is a picture of an MOD. You have two rings. We're going to go into detail a little bit more. You have your wedge. You have two wedges. Here, I think they're of different sizes, depending, again, that will be depending upon the size of the embrasure that you want to achieve. Okay, so placing the sectional matrix system, place approximately the size of the band interproximally. Insert a wedge to create a gingival seal. These wedges come in all different sizes, and the first thing that you are to do is to place your sectional matrix, and then you gently insert the wedge at the gingival area. And what you want to achieve in this point is you want to make sure that the wedge is going to prohibit any material from going past the gingival floor. At that point, we're ready for the bitine that goes around. You do have, just like you do with the rubber dam, there is a there's an equipment, an instrument that allows you to spread these wings to place it right next to the tooth. And then it must fit snugly. It needs to fit snugly from the occlusal surface all the way to the gingival. At that time, you need to check the gingival seal. If you do not have a very strong gingival seal, it must be replaced because the material will flow through. If you do have a nice gingival seal, you need to burnish it in order to create a nice contact. So this preparation to me seems more like an alloy preparation because it is very large. It has the preparation through the isthmus, and also it includes the mesial pit. But this is the preparation that we will be restoring. Here is the sectional matrix with the wedge. The wedge is placed, but if you notice, I can see that there is an open contact right in here. And that is why it is so important to burnish once you have your bitine ring placed. As you see, the bitine ring is placed. It is placed mesial to the wedge, and the matrix band here needs to be burnished. If we're looking at this, I'm going to call it tooth number 20. This is 21. This band needs to be burnished against 21 to have a nice solid contact. Here you see them burnishing against the adjacent tooth. If you notice here, there is a little bit of an opening. This bitting ring should actually be pressed against there so there is no flash. Okay, so we're going to, let's say that we have the preparation still in enamel. Therefore, we're going to place a thin layer of flowable composite. The flowable composite should be on the pulpal floor as well as the axial wall. What I normally do is it comes out in a tip. It flows very smoothly. I would not put a lot. I would put it on the occlusal surface, and then either taking an explorer, I would run the explorer along the pulpal floor, and I would extend it on the actual wall. If you notice that it's very thick in a certain area, you can take your air water syringe, make sure that there is no water, blow out the water, and with a very gentle film of air, just blow it over the occlusal surface so the film of the flowable is even throughout the occlusal, the pulpal wall. I'm sorry. So why flowable composite first? Flowable is a very thin layer of composite and it improves the bond. I've also noticed that when I place flowable, which I always do in my composites, there is less postoperative sensitivity. The flowable layers also get into the boxer corners and it prevents voids. But if we do have the preparation that was prepared for a composite rather than going from an amalgam to a composite, you shouldn't really have boxes as a preparation. Okay, so now we have our flowable that has been placed, and we need to place our composite. Our composite is placed in the box, just like we do with the amalgam, and we make so now we've placed the flowable composite on the pulpal and axial walls, and we are ready to place our bulk filled composite. The first place that you should fill, just like with the amalgam, is into the box. There is a 1 to 2 millimeters of composite that is allowed to be placed, because if it's any thicker than that, when you light cure it, the light cure will not go all the way through. So you will have the lower level composite that is not cured and it is mushy, and then on top you have your light filled composite. If you do not light cure all the way from the bottom, eventually the restoration will fail. Okay, so here we have placed just 1 to 2 millimeters of composite. We pack it against one of the walls. When you have the box, you don't pack it like amalgam all the way through the floor. You pack it against a wall. And what will happen is when you pack it against the wall and you light cure, there is going to be some attrition and pullback. So you will have a gap. And the next layer will be packed into that gap. And as you continue to pack against the wall, first on one side of the tooth and then the other, climbing slowly out of the box, the gap will get smaller. Okay, so now the tooth not only was filled from the box, but then the occlusal surface the same way, 1 to 2 millimeters, packing it against the composite that has been already cured. We just add on top of that until the entire tooth is filled. At that point, you slightly overfill again the restoration, not too much. Okay, so at this point, the tooth has been completely filled, the matrix system has been removed, we check with a blade or a gold knife, or even with a proximal composite finishing burr to make sure that there is no flash, especially at the gingival area and along the proximal wall. The more precise we are in our matrix band system to ensure that there is no flash, this stage of the restoration to fill is much easier. If there was not a lot of attention and flash occurred at this point, it becomes quite difficult. Okay, so here we go. We are just shaping the proximal box to make sure that we have a nice contour and there is not going to be a bulbous area of composite. Therefore, the patient will be able to floss successfully and there's not going to be any gingival irritation. Okay, so composite finishing, the best way to prevent composite flash, as I said, is to control the environment and a well-placed matrix system and a wedge. Okay, the football or carbide football burr is used for the occlusal shaping. Obviously, before you shape the tooth, you're going to have the patient very gently on articulate paper, tap, tap, tap. You want to remove any contacts that are directly along the marginal ridge, as well as the junction between the filling and the tooth. Okay, composite polishing, there's rubber cups that you can polish. You have to be careful when you're using these. These are quite abrasive, and if you are heavy-handed, you can actually completely change the shape of the tooth or even open up a contact. Rubber cones for the occlusal, and you have a finished composite. Now, custom tinting and opaquing. This has to do with if we are working on a tooth surface area that you can actually see. Let's say that the patient has decalcification, or their tooth is mottled and they want to have the composite that you are placing match the tooth. There is these opaque and tinting systems that you can use. They also, if you have a metal or a dark stain, you can use an opaquer to make sure that the composite that is placed over there has the best chance of being the actual color that you place. So it opaques, and you could also mimic the surfaces such as artifact, pit and fissure sealants, but most likely from the patients that I have treated, they want to see a white filling. They don't want to have dark lines on the occlusal surface to match even the other teeth that are naturally there. Okay, so surfaces can be tinted and painted on the surface directly. Color modifiers are made to be placed under the final layer of composite. Okay, so that is essentially a review of a Class II composite. If you have any questions, feel free to write them down and we will review them in the class. Thank you so much for your attention. Bye-bye.